co-chairman's name is Elena Armelo. You can see her, I hope. Welcome to this session that is entitled New Approaches to the Management of Atrial Fibrillation. It's my pleasure to introduce the first speaker, Professor John Kahn, and his topic today will be early rhythm control. John, welcome, and go ahead.
Thank you very much, Jesus, and thank you for your introduction. I'm very pleased to be with you, but I prefer to be there in real life rather than virtually. You've asked me to talk about early rhythm control, and thank you for the invitation. So let me start by, of course, showing you I do have competing interests. Most of these are professional society, guideline, editing responsibilities. But you'll see at the bottom of the slide, there are a number of companies with which I have worked, and many of these are interested in the management of atrial fibrillation. Let me start by reminding you all of the so-called rate versus rhythm control trials. There are 7 of them that are usually quoted, starting with the AFFIRM trial in 2002. All of these trials, except the J-rhythm trial, have shown virtually no difference between rate and rhythm control. J-rhythm was a little different. It had a very complex composite endpoint, and it did show an advantage for rhythm control. But because with all the other trials, there was no advantage to rhythm control, and often a trend in favor of rate control, plus there were problems with the toxicity of antiarrhythmic drugs for rhythm control and more hospitalizations associated with rhythm control, the default or first-line therapy for atrial fibrillation became rate control. But there were other studies from the real world that were showing contrary results. See this example from Quebec. A large medical database could divide patients with atrial fibrillation into those who received rhythm control and those who were treated with rate control. And they could follow the patient over a long period of time. These 26,000 patients demonstrated that as time went by, although there was an advantage to rate control in the first months or years, the advantage changed to rhythm control as time went by. Now, because of this, we have recently seen a number of attempts to investigate early rhythm control. And the trial with which I was associated is the EAST trial. I think you'll all be familiar with this in principle. It was a trial that recruited patients with some cardiovascular risk, roughly CHA2DS2-VASc equals 2 or more. The patients were recruited early after the onset of atrial fibrillation and randomized to one of 2 strategies. Either early rhythm control, where an antiarrhythmic drug therapy or pulmonary vein isolation was instituted as a therapy, or usual care. By usual care was meant guideline-mandated rate control, except for those patients who remained symptomatic and required some rhythm control. The patients were meant to be followed for at least 3 years, and there was a composite primary endpoint consisting of cardiovascular death, stroke or TIA, and hospitalization for either heart failure or acute coronary syndrome. Some 2,800 patients were assessed, and most of these were randomized to early rhythm control or usual care. So approximately 1,400 patients per group. Patients came from 11 countries and 135 different sites. Importantly, the atrial fibrillation was acute atrial fibrillation, meaning that it had not been present for a long time. As we can see on this slide, the mean or median time that atrial fibrillation had been present was 36 days. You can see also that about a third of the patients were completely asymptomatic. A little under half were women, and the average CHA2DS2-VAS score was 3.4. About 40% were enrolled during their first episode of atrial fibrillation. There was little difference in the baseline characteristics or treatments, but there was a little more rate control in those who were randomized to usual care. When the patients were randomized to rate control therapy or usual care, you can see that they were treated with the rate control therapy in about 80% or 85% of cases, if we include combinations of traditional rate control therapy. The early rhythm control patients also received rate control. Certainly, a large proportion were treated with beta blockers. If we also include in the rate control concept those antiarrhythmic agents that also give some rate control, you can see that over 80% of patients in both groups had rate control. It fell off a little as time went by, but it remained almost 80% in both groups. Looking now at the rhythm control that was chosen by the investigator, we can see that initially rhythm control was actively instituted in 95% of the early rhythm control patients. Mostly this was flecainide, propafenone, amiodarone, or dronedarone. Only a small proportion, some 8%, received an initial ablation. By the time 2 years had gone by, you can see that about 65% of patients remained having active rhythm control. And of those, you can see that ablation had increased to about 20%, and antiarrhythmic drug use had fallen. If we look at the usual care group, remember this is not entirely rate control group. This is a group that could have rhythm control if they remain symptomatic. We can see that less than 5% were given rhythm control initially, and this rose to about 14% at the 2-year time point. If we look specifically at what happened to the rhythm control therapy as time went by, we can see that, of course, some patients died and therefore were receiving no therapy. Many of those who initially received antiarrhythmic drug therapy ended up taking no active rhythm control therapy, but a proportion of them had proceeded to ablation. We look at the usual care group, you can see that only a relatively small group received any rhythm control during the conduct of the trial. But if we look now at the time to the first ablation, you can see that there was within the first 2 years the largest increase to about 15 to 18% of patients. And by the time the trial had finished, it had got up to about 25% of patients in the early rhythm control group that had had an ablation. Now, here are the results. You can see it graphically on the left. Early rhythm control did better than usual care. You can see on the right-hand side that the first or primary outcome was reduced by 21% in the patients who had early rhythm control. And this was significant at the p equals 0.004 level. Looking at the components of the composite endpoint, we can see that CV death and stroke were also significantly reduced by 28 and 35%, respectively. We can see that hospitalizations for worsening heart failure or acute coronary syndrome were also reduced, but these particular results were not significant. Moving to the secondary or the second primary endpoint, we can see that the night spent in hospital was approximately the same in both the early rhythm control group and the usual care group. Slight excess with early rhythm control, but nothing significant. We also see that sinus rhythm, of course, was better maintained in the early rhythm control group, and that some 70 to 75% of patients, the same in both groups, had become asymptomatic by the conclusion of the trial. Now, the trial has been criticized because, of course, it's a strategy trial. It's very difficult to have a double-blind strategy trial. And there is a concern that those patients who were in the early rhythm control group were seen more times in the hospital and received more consultations with doctors. We have tried to analyze this, and you can see that that is true. There was an average of 1.94 visits per patient with the group that had usual care, and 2.13 visits per patient for the early rhythm control. So there's an increase of about a quarter of one visit per patient. We can see that this is largely in terms of triggered visits, presumably because of findings on the monitoring that was taking place just in the rhythm control group, or because of unscheduled visits due to complications of rhythm control or symptoms related to it. We can see on the graphs on the right that most of these other interventions occurred very early in the trial rather than later in the trial. Now, if we look at the adverse events that were recorded in EAST, we can see that the occurrence of the primary safety outcome was no different between the groups, 16 to 17%, but that the occurrence of stroke and death were both numerically less in the early rhythm control, but this was not statistically significant. We also looked, of course, at serious adverse events of so-called special interest, the kind of problems that we would expect with antiarrhythmic drugs or with ablation. And we found, of course, very few of these in the usual care group because they haven't had these interventions mostly, but we found even in the early rhythm control group, a very low incidence of adverse events. Now, that was the EAST trial, and it wasn't many months before we began to see other analyses. For example, American investigators reanalyzed the AFFIRM data, and they divided patients into those who had been recruited within 6 months of the study enrollment, and the remainder were those recruited after 6 months. And we can see from these data that there was no difference in terms of these main outcomes, such as mortality, ischemic stroke, and cardiovascular hospitalization associated with early treatment rather than late treatment. But on the other hand, we know from other data, perhaps which will be discussed in more detail later, that ablation can be given advantageously early rather than late. This is an analysis by Chu. It's a meta-analysis of some 6 studies, and you can see that the shorter the duration between the diagnosis of atrial fibrillation and the ablation, the more likely that the procedure was successful, and the more likely that recurrences with atrial fibrillation would be less common in the ablation group. Now, having said that, we're also well aware, I think, that guidelines are changing very subtly. These, for example, are the guidelines from the ESC on atrial fibrillation management. And this is a diagram illustrating that there are factors to assess in patients who remain at least symptomatic, either at rest or on exercise, or following cardioversion, noticing a relief of symptoms. And there are some 8 factors that are mentioned which would favor rhythm control. Now, this is a subtle change, but it's a very important change. And we can see that the guideline writers also wanted to channel patients where this decision was being considered towards EP specialists rather than leaving it to the general cardiologist or physician to make this choice. So let me finish off by showing this almost traditional diagram that I've reorganized a little. I think we're all aware that atrial fibrillation has a dynamic and progressive pathoetiology. We know that it moves from an essentially trigger-dependent arrhythmia to one that becomes substrate-dependent. And this can be a slow process or a relatively rapid process. I think we're all aware that we should be managing cardiovascular risk factors as early as we can to prevent atrial fibrillation. And with regards to anticoagulation, we should certainly start by the time we diagnose the arrhythmia if there is an underlying risk profile which requires it. And in many instances, some physicians are considering anticoagulating the patient before atrial fibrillation is diagnosed. But what we are uncertain about is symptom control. Currently, it's the main indication for considering rhythm control, but symptoms can occur any time during the progress of this disease. It can be early or late, but the later they are, the less chance we have to treat the arrhythmia whilst it's still trigger dependent, whilst we can potentially slow its progression. So if we want to use excellent and effective treatments, in order for them to be effective, they must be relatively early. Thank you very much, Mr. Chairman. Thank you very much.
Thank you, Dr. Kam. And I think we will proceed with the next presentation by Dr. Jason Andrade. And his topic today is ablation as first option in paroxysmal atrial fibrillation. Dr. Andrade, please.
Thank you very much for having me. To echo the sentiments of Professor Kam, obviously it would be much greater opportunity to be there with you all face to face, but this is a wonderful second choice. So let me just take control here. Here are my disclosures and my competing interests. And so this presentation will fit very nicely with what we've already heard from Professor Kam speaking about early rhythm control. In general, if you were to look across the European and the North American guidelines, even though we know catheter ablation may be more effective, generally speaking, these guidelines have a preference towards using antiarrhythmic drugs as a first therapeutic strategy when we aim to control rhythm. The problem with this perspective, though, is several-fold. The first is when we look at the overall efficacy of antiarrhythmic drugs, generally it's pretty limited. So we know that patients early in their treatment course who are given an antiarrhythmic drug, and if they're followed out for a year, which is a standard follow-up duration, less than 1/3 will actually be able to maintain sinus rhythm. And so having this knowledge regarding the overall efficacy of antiarrhythmic drugs may color some of our interpretation when we look back at those slides and those studies presented earlier by Professor Kam, looking at the rate versus rhythm control approach, because we know that our previous pharmacological options weren't particularly effective. Moreover, when we look at this mixed treatment analysis, so this is a type of network meta-analysis looking at randomized placebo-controlled trials and looking at the overall rates of discontinuation for each of these antiarrhythmic drugs, you see that they're significant. Amiodarone has a 3 times higher likelihood of being discontinued due to side effects or poor tolerability. So not only do these medications have a somewhat limited efficacy, but they're highly likely to be discontinued over the course of therapy due to side effects or intolerance. On top of that, when we start looking at some of the more significant concerns we have, so again, now looking at mortality, you can see that amiodarone is associated with a significant 2.7-fold increased risk of death compared to placebo. Sotalol at 4.3-fold increased risk of death. If you recall, FIRM study and AFCHF, so the two sort of landmark randomized rate versus rhythm control trials, these were the predominant antiarrhythmic drugs used. And so the question is that the fact that there was no difference in mortality overall, is that because of the therapies that were tried? Analysis similar to this has been shown many times, but we know in patients who have already failed an antiarrhythmic drugs that an ablation procedure is much more effective at controlling sinus rhythm. And so here you can see multiple randomized trials, and universally, in every case, ablation was better than drugs. The problem, though, is that when we look at these studies were performed in patients who had already failed an antiarrhythmic drug. And so effectively, the results were biased towards ablation being better because patients who failed a drug are unlikely to respond to another drug. Professor Cam already showed an updated slide. This is from the Canadian atrial fibrillation guidelines, but the principles are the same. So early in the disease, when atrial fibrillation is paroxysmal, it's a disease driven by triggers with very little abnormal substrate. So you have a structurally normal heart with a focal electrical abnormality within the pulmonary veins. As the disease progresses, the episodes of atrial fibrillation become longer. They're more likely to be sustained, moving from paroxysmal to persistent AFib, and eventually into permanent AFib. Coincident with that evolution is a growth of substrate or abnormalities within the atria itself. And so you go from an isolated rhythm disorder to something that's more pathophysiologically complex, such as the atrial myopathy. If you look at the efficacy of ablation procedures, you see that ablation works much better when it's earlier in the disease. So on this graph, you see two Kaplan-Meier curves, both looking at pulmonary vein isolation, both looking at the cryoballoon system. So now you have the same procedure being compared to the same procedure, but in a slightly different population of patients. And you see in the more advanced substrate, ablation works less well, whereas if you have it earlier, it works much better. So then the question comes up as to whether or not the guideline recommendation should maybe go the other way. So we know that the drugs are likely to be ineffective. We know that they're likely to be poorly tolerated, that they may be associated with an increased mortality, and that ablation works better than drugs. So why wouldn't we start with ablation as the first treatment? Now, previously, there were several studies looking at radiofrequency energy and comparing that to first-line antiarrhythmic drugs. The first RAFT study was small, only about 70 patients. MANTRA-PAF was closer to 300 patients. RAFT-2 was about 120 patients. The endpoints were slightly different. Blinding was slightly different. Secondary endpoints were slightly different. And the eras they were published were basically between 2005 to 2014. When you aggregate these studies, you recognize that the guidelines have not changed to date, largely because the evidence derived from these studies was somewhat limited. Either the studies were too small, or there was potential for bias in terms of endpoint reporting. There was a large amount of crossover between the treatment arms, so you're muddying the comparison and the ability to draw a conclusion. In the case of MANTRA-PAF, it wasn't a pulmonary vein isolation procedure performed, which may influence the results. And overall, the effect size was relatively small, or the studies had negative results. And you can see for the endpoint of any atrial tachyarrhythmia recurrence, MANTRA-PAF was negative, RAFT was just positive. If you look at symptomatic arrhythmia, the two studies that were negative were the blinded studies. The unblinded study was strongly positive. And so when you aggregate this data, you don't get a compelling story that first-line ablation is better. But the question arose as to whether or not a different tool set done at a more contemporary era may offer a different result. And so in the past year, we've seen the publication of 3 different large randomized studies. So the early AF study was performed in Canada. That was the study that we led. It was 303 patients, so the largest study of first-line catheter ablation. Stop AF First was the US-led study, so 203 patients. And then Cryo First was the European-led study with collaborations in Australia and South America for 218 patients. All of these studies took patients earlier in their disease, so typically highly symptomatic patients mostly younger patients with very few comorbidities, normal left atrial size, normal left atrial volumes. So structurally normal hearts with predominantly an isolated rhythm abnormality. If you look at the endpoints of these studies, you see that across all three studies, there was significant improvement with ablation, so significant benefit in terms of preventing any atrial arrhythmia recurrence. In the case of early AF, the difference to prevent a recurrence was a number needed to treat of 4 patients. For stop AF first, it was 3 patients. For cryo first, it was 7 patients. So overall, quite good results. Early AF was designed in such a way to limit crossover, so we had no patients cross over before an endpoint occurred, and we had very protocolized antiarrhythmic drug titration protocols to make sure that we had the most robust comparator group, so they could have no suggestion that we were under-treating the comparator to bias the result towards ablation being more favorable. On the whole, though the results appear visually different, it's important to consider that there is no difference amongst these 3 studies. So while in early AF, the success of ablation appears to be 57%, whereas if you go to the far right in cryo first, the success of ablation appears to be 82%. The reason why it appears to be different is just down to monitoring. So early AF put loop recorders in every patient, which means we captured every arrhythmia event. Cryo first used prolonged Holter monitors, which gives you about 60% sensitivity to detect an arrhythmia recurrence. Stop AF first used 2 Holter monitors and weekly TTMs, which gives you about a 40 to 50% sensitivity. So the reason the absolute rates differ between the studies is because the monitoring used detected different amounts of arrhythmia. But the most important thing is that every result within the study was consistent because monitoring was used the same between both arms. You saw the same relative benefit for ablation within each study. Excuse me. And then when you aggregate them, you see that ablation now significantly and consistently reduced recurrence by about 40%. So a much more consistent and dramatic result to what was seen with the radiofrequency studies done previously. If you look at symptomatic arrhythmia, we reported this in early AF, and again, you see a significant benefit. So you may argue in terms of loop recorder AF recurrence, what does it matter? Now we have symptomatic recurrences, and we see an absolute reduction of 15%, a relative reduction of 60%. So again, a number needed to treat of 6 or 7 patients to prevent a symptomatic recurrence of atrial fibrillation. Again, we had loop recorders. So in early AF, we could look at the burden of arrhythmia or how much time someone was in atrial fibrillation. The ablation group had a significant reduction of 3.3%. 3.3% may seem like a small number, but if you consider that on a monthly basis, that's 1 day less of continuous atrial fibrillation per month. And so if you do an ablation procedure relative to giving a patient antiarrhythmic drugs, you give them 1 less day of atrial fibrillation every month. In terms of quality of life score, this was evaluated within early AF and cryo first. And what you see is a very consistent improvement in the disease-specific quality of life score. So both treatment groups got better when the atrial fibrillation was treated, but the magnitude of improvement was better for ablation by a difference of 10 points. For the effect score, 5 points is considered a clinically important difference. So now you're seeing that ablation results in double the minimal clinically important difference in terms of improvement of quality of life. When you aggregate these studies together, you now see that first-line ablation significantly reduced hospitalization by about 30%, by about 60%, but reduced overall healthcare utilization by about 30%. So individually, the studies weren't powered to show you healthcare utilization outcomes, but you can see that there was a consistent trend within each study that ablation was associated with less hospitalization, less healthcare utilization. By aggregating them, you see that there is a significant reduction overall. And so now you're starting to get a more comprehensive picture of the role of a first-line ablation procedure. The counterpoint would be that we're asking patients to have an invasive procedure rather than prescribe them medication. And to advocate for that position, we want to make sure that it's safe so that we're not harming our patients. And you can see within each of the studies, there was no difference in terms of serious adverse events and no difference in terms of any adverse event. And within each study, there was a suggested trend towards lower or similar adverse event rates, meaning having a procedure was not causing an increased rate of harm relative to antiarrhythmic drugs. So if we put all of this together, what you can see is that a first-line catheter ablation approach significantly reduced arrhythmia recurrence. And it didn't matter how you measured it, whether it was any recurrence of arrhythmia, whether it was symptomatic recurrence of arrhythmia, or whether it was atrial fibrillation burden. All of those outcomes were improved with first-line ablation relative to drugs, and were very consistent amongst these three studies. We did not have individual power for non-arrhythmia endpoints within the studies, but together there was a significant reduction in healthcare utilization, a significant reduction in hospitalization. So for the healthcare system, there appears to be benefit downstream for doing a first ablation procedure. And then when you look at the risk of harm, there was no difference in terms of significant adverse events, but there was significantly less any adverse events. So on the whole, I think we can say that this point right now, based on the evidence we've seen published across multiple randomized studies performed pretty much all over the world, we see a very consistent benefit to catheter ablation with the cryoballoon, at least in the case of these studies, as a first-line therapy. So thank you very much for having me speak with you today.
So, thank you, Dr. Andrade. Now I will ask my co-chairman to introduce the next speaker. Please, Elena.
Thank you, Jesus. Thank you, Jason and John, for the nice presentations. I would like now to introduce Dr. James Freeman, who will be talking about discontinuation of oral anticoagulation after effective AF ablation. Thank you, James, for being here.
Well, thank you very much for the opportunity to speak today. So I'm going to shift gears a little bit. We're going to move a little bit away from the rhythm control aspects of AFib, and we're going to talk about stroke prevention and prevention of thromboembolism, and specifically about discontinuation of oral anticoagulation after effective AF ablation. These are my disclosures. So I'll start just by reviewing the guidelines for stroke prevention in AF. So actually the US and ESC guidelines have really come into alignment, really led by the European guidelines in 2016. So there's pretty much universal agreement that for those who are at very low risk for stroke, those are the CHA2DS2-VASc score of 0 for men and 1 for women, 0 or 1 for women. There's no role for any antithrombotic therapy. The big difference in the guidelines comes in those with a CHA2DS2-VASc score of 1. So in the European guidelines, there's a universal recommendation for anticoagulation with a preference for the DOACs over the vitamin K antagonists. For those with a CHA2DS2-VASc score of 1 for men and 2 or greater for women. The US guidelines leave a lot of leeway, actually. So they allow for this group treatment with nothing, anticoagulation or aspirin. And then as we get into a higher risk category that's definitively higher risk, men with a CHA2DS2-VASc score of 2 or greater and women 3 or greater, both sets of guidelines recommend anticoagulation and then with a preference for the DOACs over the vitamin K antagonists. With regards to patients with mechanical prosthetic valves or moderate to severe MS, both guidelines clearly recommend the use of vitamin K antagonists, and that's because of studies showing harm with the use of the DOACs in those populations. So those are the general AF guidelines for the use of anticoagulation for stroke prevention. And I think it's always worthwhile to review the data behind the anticoagulants. So the mainstay of therapy for 30 years was warfarin, and actually the comparator group in all of the DOAC trials and all of the left atrial appendage occlusion trials has been warfarin. So it's important to know the data there. And there's a really nice meta-analysis of the 6 large randomized trials that established this as a therapy between 1989 and 1992. And what they showed was about a 64% relative risk reduction for stroke with warfarin compared to control over a 1.5-year time horizon. Importantly, with aspirin only, so with antiplatelet therapy only, there's only about a 22% relative risk reduction. And so that really put anticoagulation on the map as a stroke prevention therapy. And then, of course, we've had 4 large randomized trials of the direct oral anticoagulants with over 70,000 participants. And this is a nice meta-analysis done by Christian Ruff up at Harvard. And what it showed was a trend towards a lower risk of ischemic stroke, a very clear finding of about a 50% reduction with regards to hemorrhagic stroke and intracranial bleeding with the DOACs relative to warfarin, and then about a 10% decrease in the risk of all-cause mortality, probably driven by bleeding events, and in particular intracranial bleeding. This was counterbalanced by an increase in the risk of GI bleeding, and that's been fairly consistently found with the DOACs as the one drawback to these medications. And then the new kid on the block in terms of stroke prevention is left atrial appendage closure. And the rationale for left atrial appendage closure is that very consistently studies have shown that anywhere between 30 and 50% of AF patients who are at moderate to high risk for stroke aren't on anticoagulation. I'm just going to highlight a couple studies that showed this. So very nice study of about 430,000 AF patients in the American College of Cardiology Pinnacle Registry treated by cardiologists between 2008 and 2012, and they showed that only about 50% of patients were on anticoagulation. And this was consistent across all risk categories for stroke. And then a really interesting study looking at about 95,000 patients with ischemic stroke and AF. So these are patients that have already had an ischemic stroke who were in the American Heart Association Get With The Guidelines stroke registry between 2012 and 2015. And fully 84% of these patients weren't on therapeutic anticoagulation at the time. 14% were the excusable category. So these were the patients who had subtherapeutic INRs at the time of their stroke. 40% of patients were on antiplatelet therapy only. And this is important because, we showed the data earlier that aspirin only buys you about a 22% relative risk reduction with regards to stroke, about a third of what you get with anticoagulation. And then about 30% of patients weren't on anything at all for stroke prevention. And so, why is that? Why are we not treating patients adequately with this important and effective therapeutic modality? And the reason is that stroke and bleeding risk tend to run together. So if we take the CHA2DS2-VASc score and we take the most commonly used bleeding risk score, the HAS-BLOOD score, we see that many of the same risk factors are on both scores. So hypertension, prior history of stroke, age greater than 65. And actually, renal dysfunction is on the HAS-BLOOD score and is not on the CHA2DS2-VASc score, but is included in the Atrial risk score and other AFib stroke scores. So the very same patients that are at risk for bleeding are also at risk for stroke. And so there have been a number of studies showing that left atrial appendage occlusion is comparable to anticoagulation in terms of effectiveness. And in the US anyway, we've seen a widespread adoption of this, and we've seen it also in Europe. And so the current guidelines based on the clinical trials in this space suggest that left atrial appendage occlusion can be considered for patients with contraindications to long-term anticoagulation. The European guidelines also suggest that surgical left atrial appendage closure can be considered for those with atrial fibrillation undergoing cardiac surgery. And this recommendation, I'm sure, will be strengthened in both sets of guidelines in the wake of the LAOS-3 data that was recently presented. I could spend hours talking about the left atrial appendage closure space, but this is where we stand right now. And I think by way of background, this is important background for this talk. And so, what do we do with regards to stroke prevention in patients after AF ablation? And that's the subject of the talk today. So both sets of guidelines, both the European guidelines and the most recent American guidelines, recommend anticoagulation for a minimum of 2 months after an AF ablation, regardless of patient stroke risk. And then both sets of guidelines recommend long-term anticoagulation based on the standard stroke risk. So neither set of guidelines recommend a change in stroke prevention strategy after ablation. And so that's why I highlight what the recommendations are in a general AF population, because currently the guidelines don't recommend any changes. And we'll talk a little bit about why that is and whether there's a role for that to change over time. So let's first take the issue of the first couple months after an ablation, and where is that recommendation coming from? So I'll just highlight this study, but there have been multiple studies that show that the risk for thromboembolism and stroke is clearly highest in the first couple of months after the procedure. So if we look at this data, you can see that the risk of stroke and thromboembolism is particularly high in the first month, but extends out even to month 2 or 3. And the data does show this, that the 2-month time horizon is a little bit arbitrary, and my read of the data is that you could extend it out to 3 months. In our practice here, we often will extend it out to 3 months. But the reason for this is that, we interrupt the endothelium potentially when we're ablating people's atrium, and that may serve as a nidus for thrombus formation, which can then circulate out to the systemic circulation of the brain and cause a stroke or thromboembolism. And so I think the data is pretty strong for this recommendation, and irrespective of stroke risk, I think the data is clearly suggests that we should be using anticoagulation for the first couple of months at a minimum. So what about the long-term risk of stroke? And so we did a study, and others have shown some similar findings. So in a study of about 1,200 AF patients in a U.S. community practice, so multiple practices in a multi-center study around the U.S. in the Orbit AF registry who underwent AF ablation, what we found is that oral anticoagulation discontinuation was common in the real world. So about 23% of patients in this registry had their anticoagulation stopped for patients who had a CHA2DS score of 2 or greater for men or 3 or greater for women. So clearly a group that the guidelines would suggest should be anticoagulated over the long term. And then amongst those who were lower risk, so a 0 to 1 for men, and actually it should be a 0 to 2 for women, it was about 40% of patients in those risk categories who had their anticoagulation discontinued. And then among those who had their anticoagulation discontinued, the median time to discontinuation was 6.2 months. And so we know that that in the U.S. We're seeing fairly commonly the discontinuation of anticoagulation after ablation. And that's despite data that shows that we know that recurrences of AF after ablation, while improved based on the findings that have previously been presented today and from other data, while we know that we can improve freedom from atrial fibrillation dramatically after an ablation, studies have fairly consistently shown that 60 to 70% of patients after an ablation, plus minus antiarrhythmic drug use as well, will have recurrences of AF if they had paroxysmal AF going into the procedure. And amongst those with persistent AF, it's worse. So probably about 50 to 60% freedom from atrial fibrillation, and it may be worse depending upon how good the monitoring for recurrences of atrial fibrillation are. So we know the patients are likely to have recurrences of AF in many cases. And what we also know is that AF burden is not well correlated with stroke and thromboembolism. So there has been some data to suggest, particularly recently, that a stroke burden, or rather that AF burden is related to the risk of stroke, but it's not well correlated. And we're still sorting out, the issue of AF burden and stroke risk reduction. So we saw some of the data earlier from the EAST trial suggesting that rhythm control may lower the risk of stroke, but trials have been mixed on this. And so if we look at the Cabana trial, we look at the primary endpoint of death, disabling stroke, serious bleeding, and cardiac arrest. There was no difference with regards to this composite endpoint, and no difference when they looked at stroke as a lone endpoint. This is in the intention to treat analysis. We do know that when they looked at a per protocol analysis, because there was a high rate of crossover. So when they looked at patients who actually got ablation compared to those who were treated with medical therapy, there was a significant finding at 12 months with regards to this composite endpoint. But again, no significant findings with regards to stroke as a single endpoint. And observational data has also been very mixed with regards to the stroke risk reduction after AF ablation. So some studies have shown a reduced risk of stroke and death compared with medical therapy, and other studies have shown no difference. And this is just to highlight data that we published, again from the Orbit-AF registry, showing no difference with regards to stroke, TIA, or systemic embolism. We published similar data using results from Kaiser Permanente and their health system in California. And so the data, and on that background, the data looking at discontinuation of anticoagulation after ablation, we're really left with a number of very small studies. So we have a systematic review of studies comparing continuation versus discontinuation of anticoagulation after an apparent successful ablation. In this meta-analysis, the CHADS-2-VASc score or CHADS-2 scores were 2 or greater. And we had 9 observational studies with a total of about 3,500 patients, about 1,800 patients in each arm of the study. And what it showed was no difference with regards to the risk of cerebrovascular events and systemic thromboembolism. And actually, there was an increased risk of bleeding with the continuation of anticoagulants. But if you look closely at the data, what you can see is that most of these studies were really quite small, and the confidence intervals were really, really broad across the studies. If you look at the larger studies, actually, the data does seem to suggest that there may be a benefit associated with anticoagulation. But again, I think it's very difficult to draw a conclusion based on this meta-analysis of these very small studies. So the other question that's been asked is, what about using Watchman left atrial appendage occlusion after an AF ablation to prevent stroke? And this is going to be evaluated. It's currently enrolling in the Option AF trial. In fact, enrollment's about to close. And the hypothesis of this study is that if we put a Watchman in patients either during their AF ablation or shortly thereafter, that we may be able to reduce the risk of stroke. And so this study randomizes patients to either continuing anticoagulation after their ablation or getting a Watchman during the procedure or within the first 6 months. And they're going to look at a non-inferiority endpoint of all-cause death, stroke, or systemic embolism through 36 months, and then a superiority endpoint of non-procedural bleeding. And I think this will address the question of whether we can use left atrial appendage occlusion after an ablation to reduce the risk of stroke rather than continuing people on anticoagulation. Importantly, in the US, the predominant modality will be sequential AF ablation with a Watchman in the 3 to 6 month window afterwards. But in Europe, it's more common to do these concomitantly. And currently, about 30% of the total patients in the trial are being done concomitantly. And I think this is really important because it will answer an important question, which is really, is it safe to do these 2 procedures at the same time? So not just a question of whether these 2 procedures will work and be safe in terms of stroke risk reduction over the long term, but can they be done safely at the same time? So that, I think, will answer an important question as well. So in conclusion, anticoagulation is mandatory for the first 2 months immediately after an AF ablation. I think the data for this is pretty clear. There's a clear mechanism of potential harm in that first period with disruption of endothelium. And I think it makes clear sense to continue anticoagulation for those first couple of months. And again, that could be extended out to 3 or even 4 months. Stroke prevention over the long term, really for now, I think should be guided by standard stroke risk metrics, and both sets of guidelines clearly suggest this for now. The Option AF trial will evaluate the value of left atrial appendage occlusion versus long-term anticoagulation after ablation. And we really do need randomized trials to evaluate the role for long-term monitoring and rhythm-guided discontinuation of anticoagulation after AF ablation, because we're still very much in the dark in this space. Thank you.
Thank you, James. With this, I'm very happy to invite all speakers to a discussion. I'm going to tell the audience that you feel free to ask any questions that you may have for the presenters on the chat, that we will review them and try to bring them on board so that they can be discussed by the speakers. And while we're waiting for the questions of the audience, maybe we can start with some that Jesus or myself have. Jesus, okay. Would you like to start? Or?
Yes, I have a question for John. John, you mentioned the AFFIRM trial. And I think we all have been impacted for that trial for many years. And so when I saw the EAST trial, I looked carefully because, in essence, I don't think it is that different in terms of, two different strategies. And actually, the conventional strategy in the EAST trial is more or less, although not exactly, but more or less similar to a rate control strategy. And when I looked at for example, the mean age was close to 70 years, so it's very similar to the FIRM trial. For example, percentage of patients that were included in the study that were the first episode was about 1/3 in both trials. So the population is not that different. So why do you think the results were so dramatically different? Because, in my opinion, the EAST trial is an extremely important trial because it really changes the way we should look at the atrial fibrillation process. So can you give us your impression of really why was it so different?
Of course, the AFFIRM trial was an extremely important trial, and it remains very influential. After all, it has been responsible for major changes in the strategy towards managing atrial fibrillation. What is different about EAST-AF? You're right in saying there are many similarities, but the differences, I think, first are that the median time of enrollment was 36 days following the presentation of atrial fibrillation in EAST, AFNet4. I don't know the exact timing in the AFFIRM trial, but I suspect it was longer. Secondly, of course, we introduced ablation, although only during the entire trial for 25% of the treatment group. Thirdly, we introduced dronedarone. Dronedarone is, of course, very important in the sense that it is the only trial that has ever been shown in high-risk atrial fibrillation patients to reduce cardiovascular mortality, reduce hospitalizations when compared with essentially with rate control in the Athena trial. I suppose we also have to remember the traditional explanation given for the AFFIRM trial of a relaxation in anticoagulation in the rhythm control group. Now, whether these various factors add up to anything, I don't know. But we are making more analyses of AFFIRM, and in particular, we want to know about the patients that were recruited in a duration less than the median, compared with those that were recruited in a duration greater than the median. And also, we want to know the influence of ablation. Technically, that's a really difficult analysis, as you can imagine, because it's not at the start of the study, it's preceded and followed by different therapies. So it isn't something you just very quickly report, but a very significant analysis is ongoing. And I hope it will demonstrate something for us.
How about flecainide? Flecainide was in more than 1/3 in EAST, and I think was like 3 or 4% only in AFFIRM. Could also be of some interest. Aminoran was much less in EAST and higher in AFFIRM.
Yeah, you're quite right. But importantly, I think we learned a great deal about flecainide and how to use it in patients with atrial fibrillation between AFFIRM and EAST-AFNet. We were very particular to make sure that 1C therapy was dispensed according to guidelines. In other words, not given to patients with heart failure, not given to patients who have any likelihood of significant coronary disease and ischemia. Whether that made a difference, of course, I don't.
There are some questions on the chat. I'll start by one that's directed to both Dr. Andrade and Dr. Freeman. Would you take any decisions in patients with a CHAS-VASc below 2 and the chronic anticoagulation based on the findings of ILR after ablation. Would you recommend ILR implant to all patients that you want to stop anticoagulation after ablation? Any of you, maybe James, you start, and then Jason can comment also.
Yeah, so I mean, I think if you're even considering, I think, stopping anticoagulation in patients who have an indication for anticoagulation after ablation, I would agree that ILR monitoring, to have a clear understanding of what the AF burden is probably essential. That being said, we still don't have great data for that. So that's still a kind of hypothesizing that if we can get the AFib under control, that completely eliminates the risk of stroke, and there's not some atrial myopathy that's driving the risk of stroke that's also driving the AF. And there's obviously some good data to show that the CHA2DS2-VASc score alone, even in patients without AF, predicts stroke. And so I think we need to be a little cautious about that. But at a minimum, if you're going to try that, an ILR strategy or very frequent cardiac monitoring, I think could be valuable. And if Jason's going to field this, I'd actually also be curious to hear his thoughts on the endpoint of AF burden versus freedom from AF after rhythm control studies, and the use of ILR monitoring in all of our rhythm control studies moving forward. I mean, my personal bias is that's where we should be heading, and I think they led the charge with their study. So I'd love to hear his thoughts on that.
So thank you. I guess there's like a bunch of things to address. So I guess the first thing to consider is, with studies like NOAA and with Artesia about to finish enrollment and give us some information, from device detected AFib as a concept, I would say that the only definitive thing I can say is episodes over 24 hours are associated with a higher risk of stroke, and that comes from the Van Gelder analysis. Everything under 24 consecutive hours is an unknown, and more data is coming. I don't know how ablation modulates that risk relative to device-detected AFib detected in a patient with no clinical AFib. There's observational data suggesting that ablation reduces the risk of stroke, and that is influenced by CHA2DS2-VASc. So there's a suggestion that post-ablation there is a difference. Ocean will give us the randomized data. So, I think it's a big area of unknowns. We haven't talked about whether wearables will influence any of this relative to ILRs from the clinical standpoint. So I guess a long way of answering is just from my simplistic perspective, we do ablations to make people feel better, to improve their quality of life, to give them more exercise capacity and a better well-being. So the 25% more AF I detect on an ILR relative to the symptomatic AF they feel in a clinical standpoint isn't that important to me. But if there is a decision like I'm going to withhold anticoagulation and I would use that information to change management, then yeah, I think more intense monitoring is beneficial. So then to walk into the second part of the question, I alluded to it within my presentation in terms of the differences between early AF, stop AF, and cryo first. Definitely non-invasive intermittent monitoring is inadequate when we're trying to make decisions about comparative analysis, whether it's rate versus rhythm, drug versus ablation, or different ablation technologies. You miss 50% of the recurrences. If I put a Holter monitor on and then I say, what's the burden of atrial fibrillation on that Holter monitor? I can tell you based on analysis that we've submitted that is wrong. A non-invasive monitor will grossly overinflate the AF burden relative to truth. So we cannot, even with 7-day or 14-day monitors, call AF burden, because AF burden can only be measured by a loop recorder. You cannot use AF burden as a concept from any non-invasive monitor. We just had a paper accepted yesterday in JAMA Cardiology looking at the relationship between AF burden and quality of life. I can tell you from Circados, or a previous study, that every 15 minutes you reduce AF, you bump up the effect score by 1 point. So there is a relationship. It is significant. But the interesting thing based on that analysis is it's entirely driven by patients with symptomatic AF. So the patients with asymptomatic recurrence, there was no relationship between burden and quality of life. It was those who had symptomatic recurrences. There was a very clear relationship. It worked for absolute reductions in minutes per day. It also worked in relative reductions from baseline. So for every 1% decrease you got them down from where they were, you saw a 1-point improvement in effect. So the similar type of analysis came out of Castle, but they didn't look at quality of life. They looked at hospitalization. They showed if you reduce the burden by 50%, hospitalizations were better, survival was better. So time to event as an endpoint is a historical thing that we will keep going because that's where all of the literature is, but it doesn't tell us enough. Like I say, the paper that we've submitted looking at these endpoints on non-invasive monitoring, differences between trials may entirely be down to the monitoring and no actual clinical difference between the trials. So if we want to move the field into a more definitive endpoint, I think loop recorders and continuous monitoring and burden become very important, but you just have to be careful what you call burden.
And it allows us to look at these harder endpoints in a much more clear way.
Yeah, I think we can establish relationships that we couldn't link together before.
Correct, which is hugely important.
Then I think we have to close the session.
Yeah, it's unfortunate because these are very interesting discussions and the speakers are outstanding. But in order to be on time, I think we need to proceed closing the session. Thank you to all the speakers and to my co-chair, Jesus, for a wonderful session. Hopefully next year or in the future, we will be able to have it again, but in person this time. Bye.
Thank you to all.
Thank you.
Thank you.
Bye-bye. Thank you.